All right, let's get started. Welcome, everyone. We're so happy you could join us today. I'm so excited for this conversation with these two extraordinary doctors. They are some of my mentors, and the chance to talk to them is a real gift. Before I introduce them, I wanted to give a little bit of context about HEAL and our involvement in Indigenous health. HEAL trains, mentors, and connects healthcare professionals committed to serving resource denied communities to better meet patient needs. Our fellowship supports the transformation, leadership, development, and retention of health workers working in some of the most difficult communities around the world, including in the United States. HEAL sits at the nexus right now of so much of what is happening in the world, whether we're talking about the border in California, critical issues in Indigenous health. We work in Malawi and Rwanda, and so much of that work has been impacted by massive USAID cuts. And so I think, during COVID, it became so apparent to me how important this community is. From the very first outbreak of COVID in Seattle, we had alumni taking care of patients in skilled nursing facilities, if you can remember early 2020 with COVID there. And then over the next 2 years, there were just surges in, as we all know, Mexico, India, Navajo Nation, and our health workers were on the front lines, both taking care of patients and bearing witness to what was going on. And so there's this quote by Arundhati Roy, who's the writer, the well-known writer, that says, "There's really no such thing as the voiceless. There's only the deliberately silenced or the preferably unheard." And it's so important that we hear from our frontline health workers, their deep experiential wisdom, our patients. And so I wanted to give a little bit of context of how HEAL started working with Navajo Nation. Way back in 2015, we partnered with 5 health facilities in Navajo Nation to address the health workforce shortages there. There was about a 30% workforce vacancy. And we wanted to work in Navajo Nation both because of the need there, some of the partnerships of the communities that we were connected with, and the fact that in global health, we wanted to guard against some of the voyeurism of working internationally but not committing to local work. And so over the past decade, we've had about 130 fellows that have worked in Navajo Nation. 25% of folks that have never been in Navajo Nation stayed on after their fellowship for many years. And we've had over 70 Dene fellows who have grown tremendously and are leaders in their community and have benefited from being part of HEAL. More recently, HEAL has recruited a cohort of Indigenous nurses run by Dr. Begay that you'll hear about to support their important work and forestall burnout, which all of this brings me to our incredible experts that we have with us today. And so it's such an honor to introduce Dr. Begay and Dr. Owen. Dr. Begay, I'll start with Dr. Begay. She was a former HEAL fellow in 2019. And after she retired to Gallup Indian Medical Center, I think one of my greatest jobs as HEAL was to recruit her into HEAL. And she has such a passion for supporting Indigenous health workforce that she wanted to come on HEAL and really grow a Southwest program committed to growing an Indigenous health workforce. And she's done just that in a tremendous way. And I'm hopeful that she'll get a chance to talk a lot about that. And, Dr. Begay's a former HEAL fellow in 2019. She was a fellow. And then during the COVID pandemic, we got closer because she called me kind of early in the COVID surges in 2020, and she was taking care of patients, and she was saying Navajo Nation already has such a deep workforce shortage, and there's critical COVID surge. There's nurses getting sick. The hospitals are overwhelmed, and could HEAL kind of step in and support? And so during that time, Dr. Begay and I were very much in touch, and UCSF and HEAL was able to step in and send 70 nurses over the course of 3 months. And, I was there along with a number of ICU doctors. And I think Dr. Begay became a mainstay in conversations with UCSF leadership. She presented on grand rounds and she really modeled what it was to talk about both the root causes of the surges in Navajo Nation from COVID, talking about everything from treaties being broken to genocide to all of the pieces that led to a COVID surge. And she modeled, I think, what it looks like for academic medical centers to have solidarity with communities. And so Dr. Begay has a tremendous career. She completed her residency um, in family medicine at the University of Arizona, and she worked at the Indian Health Service for 21 years at Salt River Clinic under Phoenix Indian Medical Center. And then she was at Gallup Indian Medical Center for 17 years. So she spent her entire career elevating healthcare for American Indians and Alaska Natives. And so that brings me also to Dr. Mary Owen, which we're also very grateful to have in our presence. I came across Dr. Owen's work when Keel started to talk to Dr. Owen of potentially having a partnership in Minnesota. And what struck me most talking to her at that time, maybe like 4 or 5 years ago, was her moral clarity and her commitment for the work that she does. And so over the years, I've come across a number of her students, and they always speak about her with deep admiration. And so Dr. Owen is a member of the Occoquan tribe of the Tlingit people. She's the Associate Dean of Native American Health at the University of Minnesota Medical School. On graduation from the University of Minnesota Medical School and Family Practice Residency Program, she returned home to work in her tribal community in Alaska. In 2014, after 11 years of full scope family medicine, she returned to the University of Minnesota Medical School, Duluth, as the director of the Center of American Indian and Minority Health, which is a 50-year-old center supporting Native health. Her work includes developing regional and national programs to increase the number of Native American students entering medical careers, outreaching to local and national Native leaders to ensure that the University of Minnesota Medical School remains in tune with Native American healthcare and education needs, teaching medical students and healthcare providers to effectively provide healthcare to Native communities, and developing research efforts to address Native American health disparities. As the 2020 to 22 president of the Association of American Indian Physicians, she founded the Indigenous Health Education and Resource Task Force, IHEART for short, a multi-institution collaborative effort to establish a national network of existing educational pathways for AI/AN students. And amongst all this, Dr. Owen still practices clinical care at the Center of American Indian Resources in Duluth. So I have a number of questions for Dr. Begay and Dr. Owen, and we'll also take questions. We'll try to stop a few minutes earlier. We'll go up until about 11:40, and then have some questions from the audience. So if you all can put your questions as we go in the chat, then we'll have a chance to hear from all of you at the end of this hour. So let's get started. My first question to both of you is that Native Americans are about 3% of the population, but only about 0.3% of all physicians are Native. You two are Indigenous physicians, women leaders, and are much rarer than we would like. Can you discuss the brief arc of what inspired you to become a physician? Who or what community supported you on your path? And at what point did you find your voice as someone who could create great change as a leader and as an advocate? Maybe we can start with Dr. Begay and then we can go to Dr. Owen.
All right, I thought it was going to be Dr. Owen first. But, good afternoon and good morning. She Adriann Begay and she kabahin siya. Bitani basichin. Katnasakni dashiche dot ashtia dashanan. Thank you, Shri, for that introduction. And sometimes when you reflect on what other people are saying, it's like, really, I did that, So I really appreciate that. But um, I think my journey through medicine really began when I saw someone who looked like me, who came from the same region I came from, who spoke to Navajo patients in Navajo, and really who a person who understood the beauty and the complexities of our community. So I think this really speaks strongly to the power of role modeling, and and that our young people can really see what's possible through seeing others. But then I also saw the strength in women. My mom was just has been on my foundation for all of these years and continues to be to this day. But one of the women that I always, because she was on the board of the um, um, committee that my mom was on. It was Dr. Annie Wanika, who was, grew up traditionally, but became this powerhouse during the time that the Navajo Nation was experiencing our TB epidemic, and just spoke so well in caring and advocating for our people. But then also just, besides women healers, our traditional practitioners and the elders around me who taught me that healing begins long before medicine. It begins really with listening, with humility, and with connection. Um, as far as my support through my Western education, it was really other individuals, people I worked with, people who I went to school with, who saw the potential that sometimes I couldn't see. And and then by programs like the InMed program at the University of North Dakota, where they gave us the power to believe in ourselves. And then this program provided us with mentors and really opened the doors to that academic arena where which wasn't designed for us. So I found my voice as a leader for the first time, I think, um, when just advocating and speaking to students, and you see that look in their eyes when they finally realize that they can do this too, or you explain things in a way that they understand, like from their traditional teachings, or the way you see that aha moment and you've made an impression. That's where I feel that my leadership has come. But it's really, this whole thing is not my story. It's really our collective story, that we can change the systems that we live in. And our voice grows louder, especially when we're in Native communities. And finding um, finding myself, um, just I think this is where I found my passion for workforce development, and also in mentoring, and really making those connections with, and especially like powerful women like Dr. Mary Owen, who I'm so proud of to be in kinship. So, Mary, I'll pass it to you.
Dr. Begay, very quickly, you describe often that, being a young person who's getting their care at the IHS and seeing an Indigenous doctor for the first time. Can you just talk a little bit about that before we pass it to Dr. Owen?
Um, so I will tell you, I always tell the story that what really, where knew what this was, um, that my journey was possible, was when I went on rounds with Dr. Taylor McKinsey, who was our first Navajo physician. And I was about 12 or 13 years old at the old hospital in Fort Defiance. And, I was standing at the door, and in those days, there was like 4 beds in a room. And he, proceeded to gown in a white gown and went over to the bed, and he said, yeah, to the patient that he had operated on a day before. And he said, Yat Eshiche Hashinde, which is, hello, Grandpa, how are you? And And it was like, because I grew up in IHS, I had never seen, you have nurses or um, uh, janitorial people who could speak Navajo, and sometimes they were used as interpreters. But this was the first time I saw a Navajo or a physician talk to a patient in Navajo. And, you know, can you imagine the trust that's already built instantly in that short, brief period of time? And so it was watching him and observing that little piece of time that that I thought I could do this. And so I sit here today. Thank you.
I didn't have any native doctors that I saw early on. My first native doctor I didn't see until I applied to medical school. And then for me, it was clear where I needed to go because after meeting him. But what inspired me to go into medicine was actually anger and a sense of want for justice. I had finished my bachelor's degree, was back in working in Alaska for some loan forgiveness because I'd gotten state loans and receiving my care at Alaska Native Medical Center and also at while I was working as a Native liaison for the Alaska Alliance for the Mentally Ill. And while I was at Alaska Native Medical Center, I'll never forget sitting in the lobby hearing all these Native voices of people all over the state coming together and greeting one another. So that it was just a really powerful sense of who we are. It was, hey, how's your family? All that, those connections that are always present in our community. And I also remember though standing in the hallway one day, I was in there to get checked for a UTI with a cup of urine and people going by me back and forth, ignoring me and thinking, this is my hospital. What is wrong here? And I was just so angry by it. I thought, oh, and I knew that I needed to go back to school because I needed some autonomy. So those things drove me to consider medicine. I hadn't considered it. My mom was a nurse and had experienced all kinds of racism. So in my mind before that, it was like, heck no, I'm not going that way. But that drove me. And then at the same time, when I was working for the Alliance for the Mentally Ill, I met a psychiatrist who ran the hospital who was the ultimate in communicator. And he made sure that every single patient in their family, every family understood everything that was happening to them and everything he said. So that was a different view of medicine than I'd ever had experienced. And it made me think, yeah, that's something that I could belong to. So that combination of anger, justice, seeing good role modeling and mentorship, they culminate. Like sometimes fate has things happen or whatever you believe in. So that was important for me. Regarding the mentorship, that continues to come in many different spaces at any given time. You never know when someone's going to show up and just be someone really important in your life. Dr. Begay has been someone important in my life, even though I haven't said it enough. When I joined AAIP, she was one of the presidents, and no, I think she came out. She was a president later. I can't remember, but I just remember that anger and justice has always been anger that has always been with me. It's just part of the way that I grew up. And so I often look for people who have a different way of expressing, a different way of moving forward and achieving justice for our community. Because I've got the anger down and I've got the power down, all this loud stuff down, but I don't have the gentle ways. And so I look to people like Dr. Begay to help me with that. Other mentors, frankly, because of my age, the mentorship came from white guys. That was who was out there. Those were the chemistry professors, the others who recognized a need and were there to support me through that. Regarding finding my voice as a leader, I feel like I don't think it's like Dr. Begay said when she heard you saying those things. I, I don't know that we always think of ourselves in that way. For me, it's just doing the work. I don't, you don't strive to be a leader. You don't find any inspiration point. You just do the work and you fight for your community the way that you should. I will always, when I'm getting my worst days, I'll remember the young woman that I went to court for so that she could hold on to her kids. I'll remember the man who was in the emergency department that was being ignored, that was part of my community. Those are the people, those are the things that keep me fighting this fight, or my own parents. So
Thank you. Thank you, Dr. Owen. You both touched upon this, and this might seem like a very obvious question, but in terms of why is it so important to have more Indigenous health workers, more Indigenous doctors? Yeah, and either one of you can take that.
I'm going to start this one, if that's okay, Dr. Begay.
That's fine.
I think it's really important to note to our audience and to anybody who doesn't know that we are celebrating the 50th year of the Indian Self-Determination Education Assistance Act this year. And you can't overstate how important that act was, because it gave us back the sovereignty. It gave us the sovereignty that we already had, that we deserve, that we have, that we own, but it had everybody else recognize our right to self-determination and how to run things. And as a result of it, we've started over 60% of our clinics are now run by us, right? And when they're run by us, we can institute incredibly important programs like cultural traditional healing, or better public health systems like our nurses going out and seeing our patients. Sorry for the noise in the background. This is the decide to do this rehaul right now. And I remember one time talking with a nurse up at Leech Lake, and he said to me, he was the head of the nursing, he goes, non-native nurses do just fine. They go out, they take care of the patient, they do everything just right. But it's when the native nurses go out, that's when the music starts. And I think he captured it all. And there's something about, I've had patients cry when I walk into a room because they recognize another native. It's hard to get people to understand how important it is that we see ourselves in the people who are going to administer care, that we don't have to explain everything, that they already know. So that's the power of Indian Self-Determination Act, and us running our own show and us being there to run the show.
Totally. That makes a lot of sense. Yeah, Dr. Begay, do you want to?
Yeah, I think it's not just about representation. It's actually about restoration. With Native healthcare workers, we really bring a worldview of health, which includes our land, our language, our ceremony, and our kinship. With Navajo, it's our ke. And so when our people are cared for by those who understand that our health is relational, that's where wellness is. And it involves the family, our culture, and our community. And that our outcomes well improve, we can rebuild trust, and our systems really begin to heal too. So increasing the number of healthcare workers from our own communities is how we move from cultural competency to cultural sovereignty in our communities.
Yeah, I mean, I think that's so important and so powerful. I think there's, my brief understanding into this was, during COVID, coming to Navajo Nation and working, and I was in a full PPE, and I was taking care of an elder, a Dene man who had uranium poisoning, had already chronic lung disease, and I remember, just the stress and the anxiety on his face. And there was a Indigenous nurse that leaned over into his ear as I was taking care of him and spoke to him in Navajo, and you could see his entire face kind of relax, and clearly, like, I can be practicing kind of the most evidence-based medicine, etc. And being an outsider, not being from that community, it was just like so powerful to have somebody native in the room taking care of him. And so, yeah, I think that kind of leads me to, the work that both of you are doing, the programs that you are running. How are you thinking of increasing the number of Indigenous health workers in healthcare? I think we can start with Dr. Owen. If you can tell us a little bit about your center and what is the work of your center, and how are you going about it?
Thanks for that question. As you pointed out in the very beginning, it's a 50-year-old program. It's where I came so that I could go work for my tribe. It's a program that's focused on those cultural teachings that Dr. Begay has spoken of, that we've spoken of, It's focused on our history. Before I came to medical school, I didn't have a full understanding. I know it's weird to get it in medical school, a full understanding of our rights as Native people, that our healthcare was anything but free, all of those really important topics that unfortunately are never taught in this country and never taught in a good way and comprehensively. So our school does that. I'm about to introduce a 4-year curriculum next year that'll first 2 years will be focused on just Indigenous health, straight Indigenous health lectures on all that history and how we've been impacted, social determinants, all of those critical issues, sovereignty, and traditional medicine. And then the 3rd year will be on building, helping the students move toward a capstone project where it's either integrating an institutional change within whichever institution they move into. There'll be leadership training because so many of us graduate from medical school and we don't have the leadership training, yet we're pushed into those spots immediately. It'll also teach them about how to engage in research that's for our tribes, with our tribes, and then finally to create policy. So I'm really excited about that. Probably most important though right now, besides the straight curriculum, is that we get students out into our community and we get them doing rotations at tribal clinics, because I know that once they get there, they'll see how incredible it is. I mean, we know that our clinics struggle, but there's also a team mentality and a kinship amongst the workers there, that we're all, for the most part, our goal is the same, to take care of this community, not just the individual in front of you. So those visits are incredibly important. But the other big thing, it's started by, that I started and that we continue through a lot of the work at the center, is IHEART, Indigenous Health Education Resource Task Force. And that's in recognition of, like you said, Dr. Begay, the great shortage in different areas. In my area, the physician healthcare shortage is over 60% at the IHS clinics here in the state. I'm sorry, in the Bemidji region, over 60%. And it's not just for physicians. We need dentists, nurses, veterinarians, public health workers, all of that. We have shortages. So iHeart is dedicated to getting kids through from kindergarten all the way up through practice, and supporting them with these pathways, but getting the pathways to come together and form this longitudinal pathway, which doesn't exist as it is. And it should be regional because our regions are quite different. So that's just some of the work we're doing. I'll turn it over to Dr. Begay.
Dr. Owen, just to follow up on that, iHeart, how is it structured, and when was it formed? Is you were saying that it's focused on region specific, but it's a national scale advocacy program, correct? Or
yeah, we have a
pathway program.
Right. And the leadership is basically myself, someone from the AAMC, Dr. Norma Hunter-Pohl, and also a member who's a little bit in flux right now, Reno, from AHEC, which I find to be the heart of iHeart, of the tribal colleges, American Indian Higher Education Consortium. And so we formed the leadership core, and then we have we were able to, with a grant from Robert Wood Johnson Foundation, RWJ, we were able to fund a couple of workers. So they maintain it and they meet with the regional hub leaders. Dr. Begay is one of those regional hub co-partners. She works with someone else down there. And so we meet with them to help them support their region. We're just building the foundation and the infrastructure now, and it's hard work because everybody's doing volunteer except for those paid workers. We get little tiny stipends, but the work focuses on bringing people together to connect those pathways, but also we're going to start doing some policy work within each region.
Awesome. Great. Thank you so much. Dr. Begay, can you tell us a little bit about the program you lead?
Sure. So through HEAL, I've had the awesome opportunity to start the Southwest Leadership Program. And this is where we recruited, actually, there's a timeline and pathway. We talk about how important it is to really get kids interested, and then to keep supporting them in middle school, and then high school, and then undergraduate. But our need is now. And so what this program is we recruited nurses that are already working either in an IHS facility or a 638 facility, a tribally run clinic within our reservation. And we focus on really cultivating not just these skilled nurses, but transforming them into leaders by providing them with a curriculum that's grounded in community values like leadership, advocacy. We talk about power and privilege. We talk about structural competencies. What are the barriers that they face in their work? We also connect these fellows across the region. So this year, our second cohort, we have 10 nurses from 6 different facilities around Navajo. And we want to strengthen their leadership skills while also remaining rooted in the reasons why they came into healthcare. The goal is really not only to retain them in serving the facilities that there are, but really to help them lead change within the systems that they work in. So our learning environment really honors Native knowledge systems. We use storytelling. A lot of times, a lot of our IHS and 638 employees, they don't have the time to sit down and reflect on their work or the things that are complicating their patients' access to care, but we give them time for reflection and then really collective problem solving. We also provide mentorship from our alumni who have completed the HEAL curriculum. And so no one feels like they're walking this journey alone. And so this is how we're trying to grow that Native health workforce now, not by recruiting for a pipeline, but really tending to a circle and ensuring that that fire within that circle never goes out.
Yeah, that's a beautiful way to say it. Go ahead, Dr. Owen.
I want to mention something else that I think is really important is that we have this unofficial network, and someone in iHeart called it, Reno called it the Auntie-Uncle Network. But it's a constant network that's going on between all of us in this workforce. Like, for instance, just yesterday, I met a young woman who was a nurse and a nursing student down at the University of New Mexico. And I connected her with Dr. Begay because the obvious connection. So we're always working on connecting them and supporting them wherever we're at. And I think that's an important component it's not official, it's not funded by anything. It's just important work that has to be done is connecting and taking care of these students collectively.
Totally. Yeah, I'm struck by both of you speaking about both tending to the existing health workforce and then building that pathway that is crucial all the way from preschool up until
prenatal.
Yeah, exactly. That kind of brings me to some of your advocacy and policy work. I think that there's both things that you're all working on right now, and then potentially areas that you'd like to see grow in policy to benefit Indigenous health workforce. And so, I know Dr. Begay, you presented to Congress a few weeks ago on graduate medical education and the importance of Indian Health Service. And Dr. Owen, you've been kind of a national leader in advocacy and policy. So potentially, if you all can speak about some of the areas you're working on in policy and advocacy, and then also, maybe even kind of the goals of the North Stars of what you might see directionally where we should be going as a country.
Mary, you want to go first?
Going as a country, I think just staying alive right now is a big goal.
That's a valid goal.
Yeah. But as far as I think it's also common for us in academia, there's always this push for you to just focus on one little tiny area. But in Indian country, I find that's impossible because everything affects our healthcare and people are always being hit by one thing or another. So we're everywhere. But the things that I'm working on right now are at the local level, regional level, and national level. At the local level, I'm working on, the high school graduation rate for this community here that I live in is 56%. 56%. So what happens to that 44% of our kids? They're suffering. So just working on this school district and demanding that they live up to their promises of educating our children in a good way and giving them the dignity that they deserve on and that's at the statewide level too. On a local or pardon me, 1 minute, please. 1 minute. Right back.
So while Mary's taking care of that, so we don't lose time. I think for myself, advocacy focuses on really sustaining pathways, just like the testimony for GME, a GME office within IHS, but also for workforce programs, and most importantly, just the transforming and training the nurses within my local community. But all of these pathways have to be accountable to community needs. So we push for structural changes that move beyond short-term grants, but we want long-term commitment so that our people can train, serve, and lead in their own communities. But I think Mary would agree that really at the heart of this all, our policy is really personal. Every policy we fight for translates to a student who doesn't have to leave home to pursue medicine or nursing or other allied professions. It translates to a clinic that can stay open for another year. It translates to a community who can assess long-term care right on the reservation, which we don't have at all. And then it also translates to a patient who can speak their language to their healer. So for us, I think this is what makes our work sacred when we talk about trying to make changes with policy with such a complex system.
One important area that I'm working on in that same regard, like you said, local, is that hitting that 60% vacancy rate. We need a residency program here. Students that graduate from our program end up having to go to the West Coast or other places for residency, particularly Native residency. That's what they want. We want to continue to get the training that we've got about our communities. So if we don't have that here, they're less likely to stay here. So that's why it's so important that we develop one here. And both of us are involved in AIMS to help get that going. And it's work with the tribes and also, or I'm tribal clinics, but also work with the universities to recognize that and IHS.
Yeah, I think that is so clearly needed because,
Mhm.
we all know where you train is where you stay. And
Mhm.
if Indigenous health facilities, IHS, 638 sites can have more and more graduate medical education, residencies, that's a great pathway to to retention
In
for
that same
sure.
regard, I think we all need to be investing in or pushing for our tribal colleges to get the support that they need so that our students who go there, we know that the students who go there are are the ones that really want to serve our communities, right? For the most part.
Mm,
So why not make those a bedrock of education and make it so that those students can easily transfer to these four-year colleges and do just fine? But they're struggling to do that right now. But if you build programs, if you invest in a program that allows the faculty from a university to go over and teach at that tribal college and then, trade faculty back and forth, build a collaboration, I think we'll have far better success. But we need to be behind them and make them the form, our form, Indian country's form of HBCUs, historically Black colleges.
yes, yes. There's a program in California right now with the California Medical Scholars Program that's really focusing on, you know, uh, folks from low income backgrounds of community college students and having a direct pathway into medical school. And so it sounds like, tribal colleges that's exact because they're definitely more likely to serve the diversity of California and the
Yeah.
populations that are, underserved in California.
We know underserved and students of color in the first are more likely to serve underserved and other communities of colors in the first place. So why not
Totally.
invest more in training those folks? Grow your own. Right.
Exactly. Exactly. I want to leave a little bit of time for, uh, I think for questions from the audience, but I do, to Dr. Owen, I had, you were talking about anger and survival at this moment. And I would say that, being on university faculty, myself, I think this time, whether it's the gutting of USAID or the genocide in Gaza or university censorship, I think indigenous traditions of resistance to genocide and just erasure there's a lot to learn in this moment for our country, and so selfishly, like asking you, how are you thinking about kind of within the university, and also just at large ways that you're thinking about kind of surviving this moment?
I think this commitment that a lot of us as Native people are born with to our communities helps me survive that, and also cultural, uh, getting involved in culture. But regarding the issue that you mentioned in Palestine right now, it's hard not to grieve to see what's happening in Palestine, and to know the silencing is exactly the silence that happened when we were being massacred en masse, or our communities were being killed off. So a university saying that we're not allowed to talk about something that we know we experienced and seeing it happen to somebody else is ridiculous. But yet we are living in this McCarthy-like era right now where we're not allowed to do that. So I'm not teaching a lot about it because I want to maintain my program, right? I want to
Hmm.
make sure that
Hmm.
students can continue to go through here. But I do, that doesn't silence me in the streets. I'm going to be part of a Palestinian teach-in here in another couple of weeks. And that's part of my keeping me sane. If I were not involved, I would have so much angst and guilt, and just wouldn't be able to survive. So that makes sense. I don't know,
Yeah,
how
that
do you
makes
handle it, Dr.
makes
Begay?
Well, I haven't, because I'm not in academia. Well, but I haven't had the opportunity to directly teach about events current that are currently occurring. However, I would emphasize that, you know, what I've learned through Heal is that solidarity is a part of our healing practice, and that the collaboration for me of Western medicine with Native medicine is really moral medicine, and that health is impossible when justice is absent.
That's right.
So
Mhm.
we all have to remember, that we have to be, that the humanity in people is there, and that the understanding of colonization in all its forms continues to shape nations and really affect their health outcomes.
Mhm.
So that as we carry forward, that healing and liberation are really inseparable. So we just keep going forward and doing, keep up the fight and doing the fight that what we can handle for ourselves.
That's right. Yeah. Right.
Yeah, that's beautifully said. I'm gonna call in my colleague Rachel, who I believe is has some questions that are coming in from the chat.
Yeah, great. Thank you all. Yeah, so much for the conversation so far. I'll go ahead and mention some of the comments and questions that are coming in from the chat from our attendees. So the first one looks like it could be for either one of you or both of you. But how do you implement community-defined evidence practices into your medical practice? So this is examples of like sharing non-Western practices of healing with your Native patients.
Um, I am in no, I'm not in Tlingit territory. I'm not in my own land. So for me, it's really important. One, I always ask. People don't know that we should be asking our patients and where they are in their cultural beliefs, and then I encourage people to engage if they're open to it. Don't push anybody, and then I connect them with the traditional healers that the community, the clinic that I work for, allows or has on staff. So trying to get them connected in any way that I can, but definitely asking and bringing the topic up. Just like we know that if you talk about tobacco, it helps tobacco cessation. I think talking about culture helps encourage it and make it more normal so that more people are involved.
I agree with Mary. Yeah, that's one of the things to really look at, because we talk about uh, social determinants of health, but we have indigenous determinants of health. How much of their family has been affected by trauma, previous trauma. Those stories, those oral stories that have been handed down, what do they believe in? Because we know that the things that we believe in kind of gear what our thoughts are and what our emotions are, drive our actions, and then drive the results that we get. So it's I think that's one really important part is, um, you'll see it in families, you'll see it in certain communities, the differences. And so I think understanding that community is so important.
That's something that I teach my students a lot, or every time I can, is that you've got, if to be successful, you've got to be part of the community. Otherwise, people just aren't going to trust you. Why should they? No.
Yeah. Thank you both. Another one that came in is, are there existing partnerships with IHS that are intentionally creating career pathways within and amongst AI and AN communities?
Go ahead, Dr.
There
Begay.
are there's a scholarship program. We have one for like undergraduate level that you can get through IHS for. Unfortunately, some of them are for specified, like what is the shortage within Indian Health Service. So they may specify what degree that you're pursuing, but there's that IHS scholarship program. There's also, in addition to that scholarship program, you have if you're a scholar, then you can apply for an externship. And that would be, during your time off, your breaks, that you could go work within an IHS or a 638 facility. And then the graduate level scholarship program. So for MDs, for dentists, for other professional degrees, there's that program. And those require a payback. There's a payback obligation for that. So those are pretty much the programs directly through Indian Health Service.
Yeah. I took advantage of all three of those.
Mm-hmm.
Yeah.
Yep.
And is the payback program, is that typically a financial actually paying back, or is it in time and commitment into serving a certain area?
It's a time commitment. So it's a year for year. So I got 4 years of graduate level funding and worked, with IHS, but it was my intention always to work within IHS. So it was a no-brainer for me.
Agreed. Same.
Yep. I think the only challenge is, let's say you're an internal medicine resident, but you want to go on and do a fellowship in cardiology or another fellowship. Mm-hmm. Unfortunately, there's the stipulations in there that you have to give your payback first. You have to do your time back before you can complete a fellowship, which makes it very difficult, so has interrupted some of our Native physicians from going on to, become specialists in some of the areas that are highly needed.
This is an example of some of that policy work, though. Some of us are involved in trying to get IHS to realize how important it is to also allow folks to job share and do other things, but still pay back that loan in other ways, like other programs have.
Let's see here. We also have one other one. So you both have talked about the ongoing workforce shortages within Indigenous communities. In addition to increasing numbers, what are key components for retaining Indigenous health workers for the long term?
Go ahead, Dr. Begay. No, you called that one on me once. I'm doing it for
you. One of the things that I have found through the leadership program that we're running is that, a lot of times, just like Mary said, she learned about all of this, maybe historical trauma, the history, that our people went through, and we don't, sometimes it's really important to give that backbone of history again, to review it again, and then make that connection to how this has affected the health outcomes of our patients. They get a perspective of like, oh, that's why we have such a high rate of substance abuse. That's why we have, and it's one of those things where I really like those aha moments where some of the fellows that are in our program currently, they're like, we talk about structural competency and things, and they're like, that's what I do every day. I can put a word to what I do. I can put a term to the work I do. I can, um, so it's, I think it's, yeah, I mean, that's the simplest explanation I can give.
I'm going to
Sometimes
be
we say in healed, like the you're swimming in the water of injustice, that it's even hard. Like a fish doesn't recognize they're in immersed in water, because and to hold a mirror up to it and have mentors that talk about it, like the both of you, I think is incredibly just like it shifts how you think about health, how you think about kind of the causes of suffering, who gets sick and why, all of those pieces that, often medical schools not, or any of our health profession schools are not teaching us. Um, yeah.
I think it's important that we try to find the students, again, the ones that are going to the tribal colleges. We try to find the ones who are more likely to have that become all they do, all they think about. Like I will never work for private health. I will always work probably in tribal health, always be serving our community. And if not our community, then another community in need. So we need to find those students and then help support them all along the way. I'll say that I did leave my tribal clinic because I felt like they weren't listening about those social determinants. I kept having to give medication or tell people about yoga, whatever else for bad depression, when I knew the answer that I was going to see them again in a few weeks because they didn't have a house or they didn't have food. And my clinic refused to be engaged in those kind of things that I knew were at the core. And that was a tribal health center. And I found that
Mm,
inexcusable. So this goes back to why it's important that we lead and not just you can have a native person, but it's got to be the native people who are committed to these understandings of these structural issues, being in the leadership, like kind of like what Dr. Begay was saying. It's not just our representation just because people need to see a native face, it's because we know how to do things better, I think.
Dr. Owen, you're talking about kind of that clarity that you'll never work in private medicine. You always serve tribal communities, and then supporting tribal colleges. Do you think that, at what stage do you think that people can be shaped to have that clarity that I am going to be committed for the long run to, you know, resource denied populations, tribal populations, fighting on alongside for solidarity and justice. Where does that happen? Have you seen it happen in amongst, folks that are later on in med school, or do you feel like people come into that with that consciousness and then that just continues throughout their career?
I think most people come in with it. But once in a while, like Dr. Begay said, if you immerse them in the teachings, they can have that aha moment. I would love to build a program where our students the right students get to go hang out. Um, what is it called? Not a mentorship. It's something when you go and hang out with someone who's teaching you along the way. I can't remember what we used to call that.
Apprenticeship.
Yeah, apprenticeship, right. With a traditional healer, like a first year medical student comes along, the right one, and they go and apprentice for 4 years.
Mm,
And the
hmm.
first year, they might just be collecting wood for for the fire or whatever they think is important, maybe shoveling that guy's driveway. But they're learning alongside all those critical teachings that we have about humility and how to take care of people at the same time. Now, that's not quite what you're asking, but I think that's some of the sort of teaching that we need to have more in place.
That's so true. I think I had a global health mentor, Paul Farmer, who you might know, that always said like connect yourself to the community health worker in Haiti and
Yeah.
you'll learn more than, and
Oh,
you'll
yeah.
be politicized. You'll be kind of
Yeah.
shaped based on that experience. And, why that's missing in our health professions is, just uh, I guess it's not a mystery, but it shouldn't be missing from
Can you
our health
imagine if
profession.
medical students went and spent a year with community health workers like in Alaska, where they're in the village, that's all they do? They're the backbone of our system.
It would change the entire profession for
Yeah.
sure.
Yeah. Might irritate
Um,
some villagers, but yeah.
uh,
Um,
I want to see Shri. Is it okay? I want to squeeze in one last question, and then I will pass it back to you, Shri. But I think this question, if any one or either one of you could answer it briefly, but to anyone mentoring medical students, if any, what do current medical students or pre-med students need the most to be successful? Are there any resources you found to be supportive?
I think, we know that really medical education really goes far beyond academic preparation. We need we need to feel that we belong to something. We need mentorship and we need purpose. So, the rigors of medical training, you experienced it or are experiencing is can be really intense. And sometimes, especially for students who are first generation students or indigenous or come from rural communities, it's even harder because they feel that isolation and there may be a cultural mismatch within the systems that are not built for them. So really today really requires more than intelligence. It requires structures of care around the students to nurture who they are, what meaning they bring to themselves and to the community. So, and as far as supports within, I think institutions hopefully that have really good holistic admissions and advising approaches may probably have better support systems than ones that don't. So Mary can probably give better examples than I can.
I wish that were always the case, Adriann, but I don't think it always is. But in any case, and it might ebb and wane. You might have good program directors in at one time or good people doing the work at one time. But I think what I find students really need is a few things. One, they need to be reminded constantly about medicine being a team sport, that we turn to each other all the time, and you're going to continue to need to turn to one another, not just for consultation, but also like, hey, man, this just happened to me and it's horrible, and I need to talk through it with somebody. Also, checking in with your students. I find students don't check in with me nearly enough. I don't know if they're intimidated or what the deal is, but I have to reach out and take time, make them get in my office and then have a conversation with them to find out what's really going on and making sure they're okay. And then finally, I would say we need to get our students out in community so they get used to what that looks like. And I don't just mean one time they go to a powwow. I mean, they need to get out in community and be part of it to understand what our folks are going through, to get to know people.
Thank you both so much. Shri, I'll go ahead and pass it back to you.
Awesome. Well, I know we are beyond time, so I just wanted to extend a huge thanks and gratitude to our panelists, Dr. Owen and Dr. Begay. I think you all kind of saw the gems that they are, and just hearing from you today, and so grateful for your advocacy and your work. We will send out a recording of the webinar to all of you, so if you all can share it with your communities, that would be great. Anybody who's interested. And then I wanted to just say that this is the first of a series of conversations that we'll be holding because, as I mentioned, HEAL sits at this nexus of a lot of that's happening in the world. And so our next conversation is going to be about U.S. immigration policy, some of the ICE raids in communities that are dealing with it, a lot of our fellows that are dealing with it, and also healthcare access with all the Medi-Cal cuts. So that look forward to that in January. And then, thank you all for joining, and we'll see you soon.
Sheesh.
Thank you. Yeah.